Thank you, Bridget, and welcome everyone. My name is Lauren Levinsky, and I lead marketing here at Current Health. We're really excited to have everyone on this webinar today to talk about how Baptist Health has scaled remote patient care. Really excited to have Dr. Brett Oliver from Baptist on with us today. Baptist has been a customer of Current Health since late last year, so we've gone through the COVID-19 pandemic with them, and it's been amazing to see how they've stood up remote patient monitoring during that time, and then how they plan to scale that going forward. As for an agenda, we'll cover some speaker introductions at first. Dr. Oliver will give a brief overview of Baptist Health and how they've set up Current Health's remote monitoring platform. And then the rest of the webinar will really be a discussion between Dr. Oliver and our CEO, Chris, about how to scale remote patient care and what Baptist went through over the last few months and what they're looking for in the future. And then at the end, as Bridget mentioned, we'll have some time for Q&A. To introduce our speakers, first we have Dr. Brett Oliver, who is the Chief Medical Information Officer at Baptist Health, as well as a board-certified family medicine practitioner. In his role, he works closely with the Chief Information Officer to develop and implement information technology across the health system. Dr. Oliver joined Baptist in 2012 and has accepted ever-increasing leadership roles while continuing to see patients in his Georgetown, Kentucky practice. Dr. Oliver is a member of the Health IT Advisory Committee for the Office of the National Coordinator of Health Information Technology and serves on Kentucky's Telehealth Board, which is a position appointed by the governor. We also have with us today Chris McCann, who is the CEO and co-founder of Current Health, which he founded in 2015. Chris has a background in computer science, and during his time in medical school, he saw an opportunity to make a broader impact in the healthcare field by designing technology that could provide hospital-grade patient monitoring within the home. So with that, I'm going to turn it over to Dr. Oliver to tell us a little bit more about Baptist Health.
Thanks, Lauren. So Baptist, we're a 9-hospital, 450-plus sites of care organization in Kentucky and Southern Indiana. And this slide just shows our mission. Baptist Health mission is to demonstrate the love of Christ by providing and coordinating care and improving health in our communities. There's a listing of our shared vision and our faith-based values, which most recently we added joy, which was a nice addition. Next slide. We're a $3.4 billion organization, and this slide just kind of highlighted some of our community benefit that we've seen over the last year. We are a nonprofit organization, and so all the money above our costs go back into our facilities as well as our communities directly. Next slide. And it's just a nice slide that shows the service area that we have. Again, we have one facility, our Floyd facility, which is in Southern Indiana. The remainder are within the state of Kentucky, but have influence into Southern Illinois, Tennessee, West Virginia, but mostly the state of Kentucky. And you know, there's some nice rankings there of births and admissions, open heart surgeries, et cetera, just showing that 1 in 4 cancer patients and 1 in 5 births occur at our facilities. And with that, I'll let Chris share about Current.
Thanks, Dr. Oliver. Hey, everyone. At Current, our first focus is the monitoring of the patient. So we are pretty unique in the space in that we can deploy continuous monitoring of vital signs into the patient's home. And you can see on the slides here our first device, which is the one with the blue cradle, and we've just released our second device, which is about the size of an Oreo. So this gives us incredible depth into a patient's health throughout the day. We also then partner with a range of other products and devices that are best in class at collecting other metrics and health indicators. So that's things like Dexcom for continuous glucose monitoring. And then lastly, we collect contextual information, so things like symptoms and demographics. Our focus is to capture the broadest possible picture of patient health at home as we possibly can, and as passive a way as possible for the patient. We then transmit all of that information out of the home. And our goal, first and foremost, is to try and use that data to identify the onset of deterioration or disease onset at an earlier point than would otherwise be possible. We then present that information and the health data that we've collected and that call to action on our clinical dashboard, or can integrate it into the EMR. And indeed, we have our own 24/7 registered nursing team who can assist with that patient assessment and triage. And then the last part of what we do is on the patient engagement side. So once we've flagged that a patient is at risk of deterioration or disease, we want to make it as easy as possible for the physician or nurse or care manager to treat that patient, assess that patient via video visit, help that patient understand their condition and send them reminders to drive adherence to that post-discharge pathway. We are currently based across Boston and Edinburgh, hence my crazy strong Scottish accent. Absolutely thrilled and honoured to be able to stand and speak alongside Dr. Oliver today. Without a shadow of a doubt, Dr. Oliver is one of the smartest people I've met in US healthcare. It really is an honour to get to talk to you about this today. So thank you, Dr. Oliver, and I'll hand back to you.
You're too kind, Chris. I appreciate it. It's been a great partnership. We wanted to just kind of break down sort of how we got here as an organization, and then the teams that we utilized. You know, and with our remote patient monitoring at Baptist, we did have some devices at the time. It was very device-based. We didn't have a standard platform, and honestly, they just weren't being utilized. It wasn't until I was probably 6 months into sort of my personal investigation that I realized we even had devices at some of our facilities. So clearly it wasn't a systems initiative, and they weren't being utilized very well. And so we had some original goals to our program where we clearly wanted to improve the quality of care that we provided at Baptist, and we feel like the home, you know, is that area that had been neglected, sort of a black hole in terms of data and reaching out to the patient there. We wanted to meet our patient expectations as consumers that some of their care needs to be delivered outside of our walls. We wanted to increase our efficiency, lower our costs, expand our access, and reach with these efficiencies without having new bricks and mortar built. And then also in Kentucky, we're still generally fee for service in most of our areas, but our value-based care team and risk is right around the corner. We recognize that, and it was also in preparation for a value-based care world. We had this tool. I was really looking more for a platform, not as device-based. I feel like the device will iterate a number of times, as you can already see with Current, but I wanted a partner that knew that the key was the data. We've had the ability to get a patient's weight, single metrics forwarded to us, whether it's just the patient giving us a call or other modalities. I wanted to see, can we leverage artificial intelligence and machine learning to find those combinations of vital signs, those combinations of metrics that would find a deterioration or whatever the clinical point of care that we were looking for, find that earlier before perhaps even the patient would know that. And so that's where I started talking with Chris and Current a couple of years ago, actually. And so as we were going through our due diligence and feeling each other out and learning, we finally got to, at the end of 2019, the plan for a COPD, CHF trial. Those were two areas that we had a lot of opportunities to decrease readmissions and to extend our care into the home. And so we decided to use our Baptist Health home care team. That's our home health service within Baptist. So we had the providers taking care of, say, a CHF patient in the hospital that would then hand them off to the Baptist Health home care team that was responsible for the monitoring. They also previously had the experience with interacting with patients and escalating concerns to a provider. So that kind of was built in. And then we had the Current Health Care actual monitoring team, that first call when something didn't look right or they weren't receiving the data. Did the patient take it off? Had the batteries low? Or was there a significant problem that then would get triaged to our home care team? So that's kind of how we got started. We got into an initial pilot, and we were probably 8 or 10 weeks into that pilot when COVID hit. And as part of our surge planning, bed availability, those kinds of things, we decided we needed to pivot with the monitors that we had and monitor COVID patients. Fortunately for Kentucky and Southern Indiana, we were not hit like a New York City or Italy or Seattle, but we had contingency plans for what do we do? How do we care for a patient in a hotel room or a university dorm if that is where the quote hospital bed is? And so we were planning for that, as well as trying to safely discharge COVID patients home. For those of you that aren't familiar or don't remember, early on, these COVID folks were staying in the hospital 3 and 4 weeks, just concerned that because the deterioration could be so rapid, that we were uncomfortable. It was just such an unknown. And so being able to send the patient home with this continuous monitoring was both a comfort for the patient, which is the most important thing, but it was also comfortable for our clinicians that, they just had watched some of these folks deteriorate so rapidly, and to be able to say, okay, I'll let you go home, but you're going to need to wear this device, freeing up a bed for somebody else. Again, fortunately, we didn't get to that point where we had to send people home that we clinically were not comfortable with. However, we ended up with quite a few that went home on the monitoring service. We did not, let me kind of caveat, we did not lock in the providers to say you could only use this for COVID patients. If they had a clinical scenario that they felt this was appropriate for, we allowed them, they were able to order that, and home health would continue to take care of that patient. And I mention that because one of the neatest anecdotal stories early on was we just had rolled out the COVID piece to folks, and one of the first patients at one of our facilities went home with a COPD exacerbation, or had been in the hospital for a COPD exacerbation, went home. Even through patient education of both the patient and her husband, one of the first nights home had an episode of deterioration that the patient's husband thought she was just sleeping. Perhaps she was, but her O2 sats were in the 50s and 60s. And it was because of that continuous monitoring that we got her back to the ICU, made some adjustments in her medicine, and really, I think, saved her life. And there are stories like that abound, in the home monitoring literature, but it was really a personal thing that really hammered it home what we were doing was the right thing. So our goal with the COVID monitoring was to prevent readmissions, and then if we had a surge, to have bed availability by utilizing the devices and sending them home. Anecdotally, I've had a couple of my patients that I see that went home with the device, and one woman, after about 6 weeks of continuous monitoring, I felt like we had to pry it off of her. She just loved the comfort and the security of knowing that somebody was keeping an eye on her 24/7. It was just kind of a new concept, rather than somebody calling and checking on her, maybe coming out a couple times a week or asking her to check a vital sign. To know that she was constantly being monitored was very comforting to her. Chris, I don't know if you've experienced that a little bit in other use cases, that patient comfort level with it, or not. Any comment there?
Yeah, I think that's been really interesting to us, and we've seen the story you just shared of having to prize it away from the patient, and we've seen that time and time again across the United States, where patients tell us that they feel safer, they tell us they feel more secure, knowing they have this continuous connection. And I think it'd be really interesting to explore how that actually in itself has an impact on health outcomes and an impact on readmission rates. If we're creating this better feeling of confidence in one of the most vulnerable periods that they have.
Yeah, I'm almost wondering if, as a separate measure of what's keeping folks out of the hospital, if it's a CHF, say, to decrease readmissions, yes, we think we can pick up on deteriorations and intervene earlier, but also what is that fear factor of, I started to get short of breath, so I ran to the emergency room, versus knowing someone's keeping an eye on me and will reach out if I, reach a certain threshold. So I definitely would like to see if that is true and not just anecdotal, but it hit home to me when one of my patients, when I was saying, hey, Karen, I think we can stop that monitor now. And do I have to? Was the reply. So yeah, it was neat to kind of see. Lauren, next slide. Just going to walk through what our workflow was at Baptist for the COVID patients. So we're an Epic shop. We just really added on to our home care order. Unfortunately, just trying to stand this up in a couple of weeks, we didn't have the ability to get a relationship with other home care companies or things. So to make this referral, we had to have a Baptist home care team in place there. And I say that in that we have one hospital that does not have a Baptist Health home care team serving that facility, so they couldn't participate. But the provider, say the hospitalist getting ready to discharge a COVID patient, wants that monitoring, places essentially a home health order that's got the current monitor as part of the order. Then the kit, we did two ways. We initially thought about giving the kit to the patient at discharge. We ran into all kinds of logistical problems early on. If you remember how difficult PPE was and isolation was and all of the concerns about running out of supplies, that we really wanted to give the kit to the patient while they're in the hospital, go over it with them. But we were very concerned about 24/7 coverage in some of our facilities, as well as is that a waste of the PPE that we have to gown up a care manager to go in and go over it. So we ended up with delivering it to the patient's home. And then the current healthcare team does that initial monitoring. And then if there's something that reaches our parameters that we outlined and it wasn't just a technical issue, then they escalate that to our home care team. And then the home care team already had built-in escalation points to get with a physician or to triage the patient to the emergency department if necessary. We definitely, one of the lessons learned I can mention here right now is we were way too tight on the alarms early on. I think a lot of that came out of not understanding COVID as well as we do now. Not that we're encyclopedic about it, but early on, there was a huge concern of rapid deterioration. So I think we set our O2 sat thresholds a little high and certainly learned a lesson there. And it's probably a good time to point out one of the major adjustments we've made recently in some of our alarms really involved two different vital sign parameters at one time. And, that's kind of unique too. And that was what I was looking for in a platform where I can say, if the O2 sat is below a certain threshold and the respiratory rate is this and the heart rate is this, or, some combination thereof, that's pretty complex, obviously, for a patient or even a provider with some kind of sliding scale algorithm at home. But this obviously can do it automatically in the background. And then, of course, once the patient's through, discharging them from the program and the kit's picked up. And for us right now, they've been sent back to current for sort of processing, and then they send us the kit back. Chris, anything to comment on there?
No, I think what you said is exactly right, and it's been a learning curve for us as well to understand how continuous monitoring is awesome, and it comes with some interesting challenges as well. If we take respiratory rate as an example, and when we were earlier in our development, setting a simple threshold on respiratory rate sounds great, except in the home, and let's say some of these patients have heart failure, they walk from the living room to the kitchen and their respiratory rate's above 30, straight away. And I think the interesting thing for us is how do we adapt continuous monitoring to the home environment such that we're both sensitively and specifically giving an alert. And I think your example of combining multiple vital signs together has been a really important evolution in that journey for us to try and get the right alert to be generated at the right time.
And also, I should have mentioned too, we also have the ability on an individual provider level, if I had gotten alerted with my patient, I could have adjusted her particular alarm settings myself. Like, wait, that's too tight. I know her, or that needs to be escalated. I know her better. It has the ability to do that. As far as the monitoring piece goes, right now our care managers log into the current health dashboard, which is a separate dashboard. We are, part of that was we needed to get this up and running quickly. Clearly, we want this integrated into the EHR so our care managers don't have to go multiple places, providers don't, et cetera. We also did not have Epic's, or do not have Epic's home care module, which is referred to as Dorothy, but we are currently building that out, and during this build, we'll integrate the current workflows and dashboard into the care manager's view so they don't have to go separate places. I think that's key. at least from a provider's perspective, it has to be similar for a care manager, but you're not going to get a physician to go to multiple dashboards, even if it's for the best interest of the patient. It's just not. You've got to get it integrated into the one place where they do their work. Next slide. So our goal was to keep the COVID patients from bouncing back to the hospital. And we've had now the 270, a few of those were the CHF COPD early on, but the majority were COVID patients. And to date, we have not had any readmissions. And as you see there, the average days monitored were 12. But I think my patient tripled that, but she might have skewed the results a little bit. But just out of curiosity, it was a little over a week, or a little under 2 weeks, excuse me. And I think probably one of the things that I would maybe start our discussion with, Chris, that I've learned and love to get your feedback on is clearly we rolled this out faster than we were comfortable with. I had to hold a lot of technical hands and operational hands to say, I know what your normal process is to roll something out. I know we want this kind of education. We want to get in front of this group. We don't have that luxury right now. This has to be in. And I got some appropriate pushback at different points, but it was a little bit of a different project. Typically, I would have much preferred to be out in front with the providers, a little bit more nursing groups, things that we got out email kind of communication, but it would have been preferred to have in-person meetings. How have you seen that be successful as other organizations are rolling it out in terms of the buy-in piece for providers? Yeah,
so I think one of the biggest learning journeys for us as a company has been understanding that the success or failure of these programs is not actually a function of the technology itself. It's a part, of that. Like the patient simplicity and setup and so on is really critical. But actually, the bigger part has been the workflow, things like, how is the patient educated about the program and the purpose of the program, at what point are they enrolled, and how are they activated successfully, and what does the response look like to that. And I think the truth is that we see every hospital, every health system has a slightly different approach to that. And I think part of our journey has been understanding how do we help health systems and hospitals go through that journey of understanding the full pathway. And we've matured a lot in this regard since you and I first met, and make sure that we ask these questions and work it out together, and certainly do that as quickly as possible, but really try and set the whole program up for success. Because if you simply just throw in the technology without that wider clinical pathway, it's much more challenging to ramp it up.
Yeah, I think we saw that early on in the COPD CHF pilot. The scripting that we had for some of the nurses that were applying the device the first go around, we had to collectively work on that. There's a difference between saying, Mrs. Smith, this is a critical part of your continuing care plan. The reason you're able to go home now is for this monitor. Let me explain to you what it's about, versus if you want to try this, we're just kind of, piloting this device to see how it does. There's just, and I don't blame the nursing staff that we were utilizing. It was on me to not think through that, but you're exactly right. Showing the patient that this is a critical part of your care plan. And again, the outcomes that we're looking for. Mr. Johnson, you've been in the hospital 3 times in the last 4 months with congestive heart failure. We don't like that as much as you don't like that. And let's use this device so we can keep you out. And then somehow connecting the patient with their caregiver, or at least someone in their caregiver's specialty. It's not, no offense, but it's not Chris opening up a video saying, hey, welcome to this device, but it's maybe somebody from Baptist Health saying, hey, I'm chief of cardiology, and I see you've got this new current health device. Let me explain to you why it's important, and you're going to follow up with your doctor. Again, trying to individualize that a bit. I don't know if you want to talk about, because we haven't utilized it as much as maybe we could, the tablet that comes with the device and how that could be utilized.
Yeah, I think the patient engagement side is by far the hardest challenge in any of these programs. And I think there's a couple of things we've learned. One is that the single biggest determinant of success is the involvement of the healthcare professional, the doctor or the nurse. If the first time the patient hears about current health is from, the UPS delivery man, then that leads to, in our view, poorer outcomes. Whereas if the nurse, the care manager, the physician is, as you said, reinforcing the importance of the whole thing and the personal value incentive for the patient, then we see much greater success. And it has led us as a company to make sure we focus on that interaction, and the physician and nurse really has to be with the patient at the very center of it. And then secondly, we're really trying to make the interface we give to the patient, the tablet, almost the center of the current health experience, and facilitate video visits within that, drive reminders to the patient through that to try and help them remember to complete the many different tasks that they might have to do as part of any transitional care program. And now we're starting to build into that. How do we show them all of the data that we've collected on them, but in a way that doesn't create anxiety within the patient? It can actually be used to educate them and even make initial recommendations to them, and really to engage them as far as we can and make them the center of this. I think the other thing we've learned is about patient simplicity. And, I think it's easy for technology companies to forget that a lot of these patients are elderly, they're over the age of 75, certainly in our programs. And in many cases in our programs, they're dual eligible. And they might be very nervous and even scared of technology. And a real challenge is how do you make them feel comforted and that this is something that they can easily do, even at the most vulnerable moment in their lives. And to me, those are the most interesting and challenging product development areas that we focus on.
Yeah, I want to play off of what you said. I totally agree that simplicity is key, and particularly for the elderly, where maybe you've got some visual or even tactile impairments with the device. But I also want to debunk a little bit of the myth that, well, because it's technology, I should leave some of my older patients out. We not to go off on a tangent here, but we like most organizations had a huge surge in video visits during March and April, and continue with about 10% of our visits being virtual like that. But it was fascinating to look at the demographics from those video visits, that we had about 80,000 visits over a span of about 60 days, and 5% of that 80,000, so not just a couple of visits, but 5% were patients over the age of 85. And now I suppose you could argue that some of that was, family members were helping them out and doing that, but we had a vast majority, 65, 70% were over the age of 50. So I would encourage people not to use that like, well, that population is older, they're not going to be able to figure this out. I would definitely argue against that, and almost think it's a little ageism, paternalism kind of creeping in there, that the majority have smartphones now. Not everybody. I practice in a more rural area, and I have folks that have a flip phone or don't have a phone at all, and there are some limitations to bandwidth and internet access. Several of our locations, as Chris and Kern found out when we first rolled out the initial project. But I think as a side note, to not eliminate an elderly population because you think they're not going to be able to handle the technology. But totally agree with the simplicity is important.
I could not agree more. And I think from a cultural perspective from Current Health, one of the areas that we've spent a lot of time working on is the final mile into the patient's home. And actually, the greatest challenge for us is not actually the monitoring of the patient themselves. It's the final mile. It's things like connectivity and setup. And there was a piece in the Washington Post I think last month, talking about the same issues that you are about the bias within video visits to younger populations. And I think it suggested that 1 in 4 elderly patients or Medicare patients did not have home internet, did not have smartphones, and there's shifts depending on the state, obviously. But this article, the way it was spun afterwards was that these patients were effectively, unaddressable, and I think that's just lazy. It's incumbent on us as technology companies and working with partners like Baptist to figure out how we get to these patients, because arguably these are the patients who most need this kind of service. And I think just saying, well, they're too old, or we don't have home internet, or they don't own a smartphone, that's not an acceptable excuse to not make this kind of service accessible to them. And it's certainly something we really strongly believe in, that everyone should be able to access this.
Yeah, it goes back to the internet really needing to be a utility. For full transparency, I mean, I'm a small government guy, but I really, seeing this up close, like our government in Kentucky has done a great job for the middle miles, to use your last mile analogy there, Chris. But still, it doesn't. If you're a cable internet company and you've got one house per 3 square miles, it's really hard to make the business case. In fact, it's impossible to run fiber out there. There are a lot of places where there are just very few options. And again, we can get back on track here, but I think that is an important piece to remote monitoring and really any kind of digital care that we're running into, creating some disparity.
I couldn't agree more. Well, if we continue into the clinical workflow, in your view, how do you successfully integrate this kind of technology into the clinical workflow? What do you think needs to be considered in advance, and what do you think is important to make it fit successfully into workflow?
I think first it starts with a really strong operational partnership and having enough time to establish that if it's not there. COVID was kind of unique in that our entire organization was focused, right? I mean, other projects got put on hold. I'm sure it was similar, around the globe. And so that allowed for us to roll this out and get everybody's attention more quickly. Even though I would have wanted more time, you had sort of an immediate operational buy-in, partnership, whatever, with just a few phone calls. Rotating back to CHF now, it's really establishing that governance that you need, not just what device are you going to use or what platform are you going to use, but who can order it, who monitors it, does it dovetail with a CHF clinic that you're standing up or that's already stood up. We've got all kinds of different initiatives for CHF. We have a pharmacist run CHF clinic in one of our areas. We've got a couple of APRNs that are under a cardiologist that run them, again, with the strategy of trying to decrease readmissions. And we have some access issues for primary care as well as cardiology in some of our areas. So they stand these clinics up so somebody can get in quickly within 48, 72 hours post a hospital discharge. This can fit into those strategies, but you have to understand what those operational strategies are, and you have to partner with them. What I try to share with my physician colleagues that are in leadership or other administrative leaders in different service lines is, please don't come to me with your shiny object. Just tell me what are you trying to solve? Oh, we're trying to solve CHF readmissions. Then let me go to my team and technology based folks and say, do we have any tools right now? That's the big thing, is sometimes we already have tools. Like, it would have been great for me to understand we already had some monitoring equipment 2 years ago when I first got started. I had to discover that by happenstance when a contract came up for renewal. But it's because we didn't have that strong operational partnership. It would have been the first conversation I brought up with, say, the cardiovascular service line leads. Hey, I'm looking at this new current health device. And they said, well, we already have these devices. No, but that conversation didn't happen because we didn't organizationally have that structure back then. Now we do. And I think given enough time, that's key. I can't roll out a tool just because I think it would work. it has to go along with whatever that operational group, their goals. And so I think I know that's probably goes without saying, but there's no way you can't not say that because it's just so key. And now when you've got avenues of reimbursement that you didn't have, at least from CMS, that changes the game a little bit as well. So you've got our initial pilot, we were looking really at cost avoidance, trying to keep people out of the hospital, or at least keep them from a business perspective, keep them out of the hospital for 30 days until you didn't get dinged for a readmission, which that's terrible. That's not the business model you want. But to now, CMS has got codes for remote monitoring that, no one's going to break the bank with it, but does it at least cover the monitoring itself? So you're improving the quality, you're covering your costs, and then you're lowering your avoidable costs. So I think you've got to understand what's your organization strategy, or at least at a service line strategy, and then how would remote monitoring fit in. Since we rolled this out for COVID, I've had lots of great feedback from different areas of our organization saying, hey, I think we'd like to use this. Could it do this? Could it do that? So I would also say to get some of that operational buy-in and partnership, just pointing those things out. Maybe your organization doesn't have it yet and you're interested, learn about other organizations, what they've done, and then have those conversations. Would that be something that would be helpful for you, Dr. So-and-so in the oncology, service line? So I think establish that platform, and then those strong operational partnerships have to come first. And then say, okay, here's your problem. Here's the tool that I think would work best. And you keep that. Now, if you're a single facility, maybe it's a little easier, but where I've come from historically, our different facilities find their own solutions, and then IT has to support them, which doesn't always work out really well from a efficiency and quality of care perspective.
Do you face or see skepticism within your provider group when it comes to digital health and new technology? And if so, how do you try and handle that?
Yeah, that's a good question. It has certainly changed dramatically in a positive way. We had a goal, and I say we literally had a digital health, department of myself and Nick Sarantis, that I know our digital health director for the system. And we had a goal of rolling out some remote patient monitoring, getting the CHF, COPD pilot done. And then we hoped to have a couple of primary care offices that, the early adopters doing some video visits, maybe one or two specialists if we got lucky and got some momentum, because that's where we felt like provider acceptance was. Like, that's bad medicine. I don't want to do that. I don't even know how to understand that. My patients aren't going to do that. COVID hits and you don't have a choice. It was remarkable, the attitude changes. Number one, they were so thankful that we were able to roll things out and have that kind of care available. But then just dozens of times I'd have conversations with those more recalcitrant colleagues, and they're not 100%, but pretty darn close. Like, you know what, that wasn't bad. That was good. Could it do this? How about if the monitoring could do that, or the video visit could include this? They all of a sudden became active partners in the process of making video visits and our digital health better. So I think it's an interesting question, Chris, because I think a year ago I would have had a different answer. I think now we've got a pretty good acceptance. I called before we were talking this afternoon, was out rolling out a different tool that I would have probably not gotten an audience for, but it seemed to fit where one of our service lines was going from a strategy standpoint, and got their engagement. So yeah, I think there's a greater acceptance now, and for other organizations that haven't, have run into that more traditional, and they probably recognize this post-COVID, but that it's a good time before people settle back down into other workflows. Because I don't think with the efficiencies and the improved quality with remote patient monitoring and other digital services from home that you're going to go back. You can, but I don't think the patients are going to demand it differently. I've had some of my colleagues say, the patient, they just need to come in and see me in the office. And I try to have a gentle conversation with them and say, you're not answering the right question here. That's not what they're choosing. They're not saying, well, either handle this digitally or I'll come to see you in the office. They're saying either you handle it digitally or I'll go down the street, metaphorically speaking, to somebody else that will handle it digitally, whether it's a pharmacy, a national pharmacy chain, or a GetRoman.com or whatever. And so as an organization, we're looking at how do we make sure we keep that those acute care visits and things within our system, because as the patient becomes more of a consumer and recognizes the options they have, that's not the choice. Oh, I'll do it with Dr. Oliver digitally, or I'll go see him in the office. It's like, I want to do this digitally, and you'll have to, if it's not you, Baptist Health, it's going to be somebody else. So a little tangential there, Chris, sorry, but that's I think will also influence the mindset of the clinician in accepting some of these more cutting edge technologies for their patients.
Yeah, no, and I think it really rings true with what we've certainly seen across the rest of the US as well, that COVID has accelerated almost an exposure, a mass exposure on both the physician and patient side to technology in a way that had been happening, trending over the last few years, but just rapidly accelerated it, and it's almost overcame skepticism in many corners that this can't work, or it doesn't deliver patient outcomes, or it doesn't deliver ROI, and actually showed that it can work, and it can work at scale. And it's if there can be a silver lining to COVID, I think that it has helped show that things can be done differently, and that technology can actually enable new care models and can deliver a really excellent patient experience as well. How do you think about where the world will look in 5, 10, 15 years in the context of remote monitoring, digital health? How do you think that will impact the way Baptist delivers healthcare more broadly? Do you think it will shift care models? Do you think you'll be delivering care models in different ways going forward?
Oh, most definitely. I think if I was to give you even a 24-month projection, I would probably end up looking like a fool, because when I've seen what's happened, granted, COVID doesn't happen every day, but I do think the expectations from patients, it's only going to grow. And I think what this has also done if you're thinking about doing something like this as an organization, with COVID, there's been such a positive emphasis at the C-suite level, with maybe the executives in your organization that maybe didn't pay attention to those things. They were more concerned at, filling the beds and the more everyday things that pay the bills, which they need to. I've just seen kind of across the country a different level of awareness, so that if you bring a project forward, I think with both the provider enthusiasm and acceptance now comes some C-suite acceptance as well, and clearly that's important in getting things funded. But to your question, I think we've raised the floor of expectations, that patients no longer think just getting my labs in a patient portal is sufficient for my digital care. If I can make an appointment with a restaurant or something like that, why can't I make an appointment with my doctor? And there are a lot of organizations that are doing things like online scheduling, but I think that floor of expectations has been raised so much that if you're not continuing to up your game in the digital space as an organization, that you're going to be left behind, and not just left behind with patient demand and who they choose for their care, but also in that value-based world. As that continues to rear its head or becomes more prevalent across the nation, you have to find the most efficient way to deliver care. And for a patient to be able to have the care that they need done in a quality manner from home is phenomenal. Think about just using the current device. We have folks that can live as far as 3 hours from one of our facilities. Well, gosh, how many times can our home care nurse actually go out and check on a patient? And when they do, that's their whole day, or maybe they can do 2 patients. How many more can you monitor with remote patient monitoring? Check in on them by video, so you can have that personal touch, know that they're being looked after, or triage the appropriate patient. So, you know what, I do need to see Mr. Johnson, even though he's an hour away, but I also know the remainder of my patients there are stable, and I've checked in with them, efficiently. One of the things that I was thinking about, and I may have even been one of our earlier conversations a couple of years ago, Chris, was the way that digital health, AI, remote monitoring can really change how we deliver care and make it more personal. That if you had someone who was maybe elderly, needed a joint replacement, and they come to see me as a family physician for pre-op clearance, and we've got certain algorithms, certain evidence-based things that we use to look at risk for surgeries, general anesthesia, and things like that. But how cool would it be? How precise would it be to send that patient home for a specified amount of time, 7-10 days, wear the current health device, collect that personal data, and then compare them with a cohort with similar comorbidities and have had similar surgeries so that you can tailor any kind of preemptive conditioning or medications that might be needed pre-op to lower their risk of that surgery and ensuring success. It's just, there's so many opportunities to learn that it's exciting.
100%. And I think it'll be really interesting over the next couple of years as we see a continuing shift from fee-for-service to value-based care and open up opportunities for those kind of preemptive pre-intervention models. Coming back to the initial pilot, what do you think you touched on some of them already, but what do you think the biggest challenges were as you started to scale this, and is there anything now looking back that you would do differently?
Yeah, I think we definitely would have done a better job early on with the scripting for both the patients as well as because we have dozens of home care nurses, and even if we got 75% of them on a WebEx and went over everything with them, we're spread out across the state. You can't have one-on-one meetings with them, but to get their feedback. That's one of the things that I go back to one of my statements of find a good partner in your platform and who you're going to utilize, because that's been I deal with a lot of vendors in my CMIO role, and Current has been just such a great partner. Not providing great service, yeah, they do that, but listening at the level of the home care nurses. There was nothing more encouraging to me than to get a positive email from some of my home care directors that said they listened to us. They changed. We gave them this feedback and it changed. And that's the kind of relationship you have to have, because nobody's got it figured out. Even if we fast forward 10 years, there are going to be things that we learn from a clinical perspective. There are going to be things that you all learn from a technical perspective that we just continue to sharpen each other. And I think making sure that's not what I would do different, but I would have probably maybe understood that a little bit better going into it. I discovered it as we move forward, which was a wonderful discovery. But understanding that from your partner, okay, what if we come back to you and we say this isn't working? The patients don't want it. They don't understand what they're doing. What can we do? And to understand that your partner's going to say, well, that's just kind of the scripting we have, or are they going to sit down and help you hammer out where the deficiencies are and what you need as a organization for your patients? Because the use cases are nearly endless, right? I mean, we're focusing on CHF and COPD because there's the most data there, as well as that's where our organization sees a great opportunity for our patients. But it may be oncology, joint replacement, different things for different organizations. So I think we had pretty good operational buy-in early on, but what I've learned, I would get even stronger. It would be selling it even harder because it really comes down to that. Like, I can get that tool implemented for them and we can roll it out as smoothly as possible, and technically it works well. But if you don't have the buy-in for folks ordering it, again, COVID solved a lot of that. Everybody wanted help with COVID and everyone's attention was there. So we didn't have as much work to do, thank goodness, because we didn't have the time. But looking to the future, I would definitely want that buy-in from both providers and administrative folks too.
I think the scalability across different clinical areas has been an important one for us. We've really been trying to focus on how do we partner with, for example, like Dexcom for diabetes monitoring. How do we partner with other products and other solutions and deeply integrate them into our platform so that we can in effect offer something that can then be tailored and customized to each clinical area, rather than just a point solution for, say, CHF itself, and try and therefore make the barrier to operational entry lower. What's your view on the platform side? Do you see that as important?
I do. It's gotten better as we've become a little bit more systematized at Baptist, but would frequently get a single provider or provider group that had a new tool that they wanted to utilize. And, historically it would just get done. And what we're trying to do is establish platforms that then can have things sort of connected to them. So right now, if Current is our platform, and we have diabetes needs, okay, well, let's go to our platform and see. Now, I'm not saying whatever the platform is that it's going to cover all scenarios, but this, from an IT perspective, continuing to go and get individual tools for things, it's not sustainable, and we saw that. I think, to use an analogy, again, we're an Epic shop, and I know that we've been live for about 6 years. We try to stay as close to the foundation code that Epic rolls out, because we learned from other organizations that did a ton of personalization, customization of that to fit their clinicians, that whenever they're taking upgrades or getting new versions, they have to redo all that. And literally we're having, dozens of analysts have to work through that each and every time they're doing an upgrade, which is quite frequent. And actually looking to unwind that, say we have to go back closer to foundation. We would get some physicians that would move to our state and say, hey, I was at such and such organization, and this is not the same Epic. You guys bought some kind of cheap version, and and this is not what we had. And to try to explain that customization comes with a price, and it's not sustainable. I use that as an analogy because if you can establish that platform, then whatever tools you want to plug into that or whatever your use case is, you've got one thing. And I'd much rather plug something in to that platform than develop a whole new build project that somehow has to connect with the EHR and other tools when you then have that platform already taken care of.
I know we only have a few minutes left and want to have time for questions, but given your experiences, what would you share as advice to other health systems and hospitals that are looking to implement remote monitoring at scale?
So that's what, establish that platform, the strong operational partnerships, look at different ROIs now that we've got some of this reimbursement with CMS. Look at unique ways to start things. The FCC had a grant for telemedicine. There are other ways to get funding to get started. Now, that doesn't mean it's sustainable that way, but a lot of times just getting started, improving your use case to your organization, those alternative ways of financing it can be helpful. Getting that buy-in from the providers and the patients kind of early on, I think, is important, and somehow connecting the patient to their provider, or at least to their subspecialty, is important. I think it's unavoidable if you as a healthcare organization, to not be looking at remote monitoring and to hopefully do it in a more cohesive manner instead of, one of the more frustrating parts of home care for us, because we're not integrated, is signing off on home care plans, home health plans. They're not integrated, they're not read, they're not helpful clinically. And it all goes back to that integration piece. It's the reason we're integrating it into Epic. And we certainly don't have all the answers now, but I know that the digital direction, particularly with remote monitoring, is a place that we need to continue to expand and go to provide the best, quality of care for our patients, and at the location, the level of care that they need, not what we have maybe traditionally demanded. They're going to demand otherwise, and as long as we've got good evidence and quality behind it, then I think that's the direction we need to go.
That's awesome. I know that we'll get a few questions, and I'll hand back over to Lauren.
Great. Thank you both so much for that. That was such a wonderful conversation. We do have a few questions from the audience. The first one is, what does success look like at Baptist, and what ROI are you looking for?
Yeah, well, so with COVID, it was clearly zero readmission. So I was pleased to be able to tell you we didn't have anybody that was readmitted. Pivoting back, and that was it. That was it. I would add one other thing on that we learned with time. I'm sorry to backtrack just a bit, but the reporting piece, I didn't do a good enough job on our end of preparing for that. We were rolling it out so quickly from a reimbursement standpoint, because I do think it made me think of it, Lauren, with ROI and a new revenue stream. Again, it's not huge, but probably it could be anywhere from $150, $175 a month per patient that you can hopefully cover some or all of your monitoring costs. So our metrics were keeping the COVID patients at home. For the CHF COPD, it was decreasing those readmissions, improving the patient experience. I don't think we talked too much about that, but I think knowing that they're safe, but then also lowering their symptoms. If you can pick up on a CHF exacerbation or at least a change in status quickly before they become symptomatic or minimally symptomatic, you improve the quality of their life, which is huge. And then again, looking at that new revenue stream for the monitoring pieces for CMS and advocating that other payers should cover that. Hopefully there'll be some national pressure on that. They've been pretty responsive to the digital needs of the patient so far.
Great, thank you. To that point, another question is around monitoring. So you just mentioned that and how that really impacts outcomes, being able to catch things early. So the question is, why did you decide to have Current Health do first-line monitoring? And then I'll add in, maybe you could speak to how that fits into your existing workflow and any challenges or things you had to think about there.
It really was logistics. We had our hands full just getting our home care nurses, up to speed and covering what they cover, the escalations and things. So if somebody already had, we have a call center, but to scale that up real quickly and to have the expertise to do that monitoring, there's a level of expertise with what Current's monitoring team does. They know the technical things to be looking for, and then also have the experience of knowing, wait a minute, the device is working just fine, this is significant, and then escalate it to our team. Part of it was simply filtering some of that stuff for our home care team. We didn't have the group to monitor it, and then if we asked them to do that, that would probably have thrown them over the edge at that point. So a little bit of that. And then we chose our home care team because they already had pathways in place. They're used to monitoring patients from home, granted in a different manner, but then if they were out visiting a patient and needed to escalate to the provider, they had those pathways already chosen. So a question for us is, when we aren't using our home care team in the future with different use cases, what's that going to look like, and how are we going to hammer out those pathways? Because you're exactly right, they're critical, and you want the person who's going to receive the phone call to understand what they're receiving and what they're responsible for.
Right. So I think we are at time. So unfortunately can't get to all of our questions, but want to thank everyone for joining us today. And if you do want to continue the conversation or learn more, you can always visit us at currenthealth.com. And again, just want to thank both of our speakers today, Dr. Oliver and Chris, for joining and having this webinar. Is really informative, and hopefully everyone got a lot out of it.